The purpose of doing these guidance forums, we realise that we really haven't had a chance to kind of update you with where we're tracking and with things that we think are important. Obviously, we've had many discussions with many of you over the months and years about some of the burdens of antimicrobial stewardship and where we need to be going. And I guess that today it's really about trying to tell you about where we're heading as a group, because all of you are colliding with current issues coming into hospitals with EMR systems, EMM systems, other requirements, accreditation, which is going to be changing. So I guess it's a way for us to say, yes, we understand it, and we're working towards trying to minimise the amount of workload that we know that all of you do. So stepping into the talk now, I guess it's a good time to remind everyone that the National Centre of Antimicrobial Stewardship is the reason it came into existence was with a lot of the background work that we'd done with the guidance group at Royal Melbourne. And prior to NCAS, we had a partnership grant, and guidance was very important. And during that partnership grant, which is NHMRC, we also developed the NAPS program. And when we put together NCAS together with Monash Pharmacy, the Vets Clinical Excellence Commission in New South Wales, we were able to bring in our group here at the Royal Melbourne, because we were able to use our knowledge in terms of innovation to drive some of the improvements within NCAS. And so joining together was an obvious thing. So the way we've structured NCAS and guidance is that NCAS is really about undertaking the qualitative and quantitative research to inform the key targets for stewardship. And as you know, we're working in aged care, particularly with the ACT maps. We're working in general practice. We're just starting work with GP maps, which is completely new. We're collaborating also with the Department of General Practice here. The vet are doing an amazing job starting to pull together their stewardship. And then in the hospitals, we've got a real focus in tertiary with our PhD Courtney doing work in surgical prophylaxis and how we're going to enhance uptake of that, which clearly is going to be a key area for us. And also for rural regional to try and establish what kind of models of care. And that may well include some sort of innovation or technology to support that. And then in guidance, of course, we've had guidance. The current version of guidance has been around for a very long time. And personally, from my personal point of view, it's an old product and needs to be updated. We need to change the front end for doctors, and we need to improve the workflow for the pharmacists and make it smarter. And hence why we've started to move into the post-prescription review space and to try and establish data sets that are going to be interoperable for systems that are in place in hospitals. And then, of course, the NAPS is a huge opportunity for us because it really has had an enormous uptake across the Australian hospitals, particularly with 80% of the major hospitals actually participating now. And these are the ones that actually have stewardship programs in place. And with all of the data that we're getting out of that, we can feed that back into our research and vice versa. So we're focusing on the tools that people need, and I'll talk a little bit later about some of the drivers within NAPS where, as you know, all of us are doing IVR switch audits, pneumonia audits, meropenem audits, caspofungin audits, and we want to develop, like with NAPS, standardised tools so that everyone's doing the same thing and really create that research community where we can pull together our data and people have the opportunity to publish and create really important change. And because NCAS is a health services research centre, it means that ultimately we can drive policy and drive clinical guidelines and improve the standards. And at the end of that, the ones we all know that large metropolitan sites are doing very well and being innovative in their own right in stewardship, but there are many sites that don't have any on-site stewardship expertise, antimicrobial pharmacists, on-site microbiologists, some don't even have on-site pharmacists, and how we can help those sites to build up a stewardship program. So we know that the National Antimicrobial Strategy The second most important objective is judicious use of antibiotics, and it is a major undertaking for people to understand stewardship, and we still have struggling to get our executives to understand that it's not just about stopping antibiotics, but it's actually about judicious use. It is primarily about patient safety, and that is our major driver, as well as the public health response to reduce the risk of antimicrobial resistance. And this is the second objective where we fit in very nicely, which is implementation of stewardship practices across human animal care. And this is our responsibility as AMS to understand how we can best undertake this work, and also to measure and demonstrate that we're improving. There is also the implementation plan for the National AMR strategy, and this document came about as part of a national forum a couple of years ago, and all the bodies around Australia that were undertaking work towards the AMR strategy were asked to submit projects or pieces of work that will support the implementation plan. And obviously NCAS at the end of the day had about 30 mentions, including somehow it got in there that we were suddenly going to be educating the entire country, including vets and aged care and general practitioners, who tried to disavow them of the fact that, well, NCAS is not funded to do any of that. But nevertheless, we're doing, you know, we have our website and we've been working to introduce things that are important, like what to do if there are drug shortages. And I know that some of the people listening in, like Kath George, have been hugely influential, Christina, hugely influential in developing some of those tools. And so within implementation strategy, we'll continue with our focus for guidance being a not-for-profit system, which is agnostic to support hospitals to undertake approvals. And I'll explain to you a bit later what we're doing in some of the Cerner sites in New South Wales. Our indications database as well, which is a very exciting piece of work that we'll be implementing into NAPS next year. And then how can we interface, because we have access, obviously because we are the developers and designers of guidance and NAPS, how can we move forwards to have a fully integrated system to limit the amount of auditing that we need to do. It's worthwhile discussing the Stuart Bond paper. I don't know if any of you know Stuart, but he was the lead pharmacist in Illawarra, Shoalhaven, and had responsibility across Wollongong, Fairhaven and Shoalhaven, and was part of the statewide stewardship committee that was chaired by Pam Kenichi and Kate Cleasy, and it was very impressive what they did, because I've never seen it anywhere else, and it perhaps reflects the ability of the fact that New South Wales have been able to develop these really great network stewardship programs because of their area health networks that we in Victoria perhaps have never been able to do, because each site is a single site. But nevertheless, they had a centralised stewardship committee where they agreed on all the indications and targets, and they were able to create a standardised stewardship program, and the ultimate aim was to look to see how implementing guidance and what impact it had on overall usage and patient outcomes. And as you know, there's many publications on stewardship, including meta-analyses, which have definitely shown that you can improve quality of use and reduce antimicrobial costs, but there have been very few studies that have been able to show that there's improved clinical outcome. And they looked at community-acquired pneumonia, C. diff, and sepsis, which showed that there was no worse outcomes with being able to reduce the important target antibiotics. And this did include rural and regional sites. So it was a really important piece of work. And just this month, Evelina Taccanelli, who's an Italian researcher based in Germany now, her group has published the first meta-analysis, which has once and for all demonstrated that stewardship programs reduce the emergence of multi-drug resistant gram-negatives by 50%. So it's very exciting, and also C. diff and MRSA, but that stewardship programs have no impact on VRE. which is something which I think all of us are probably fairly aware of. So I guess for all of us who are stewards, there's more and more evidence about the importance of why we need to have these programs in place. Now, Australia is fairly advanced in stewardship, advanced both in terms of the US and Europe, and really, I guess one thing that stands as a part of the way that is how we have introduced approvals as one of the more common ways to manage stewardship in terms of a restrictive approach. However, we also know that the uptake of approvals, and particularly with guidance, can sometimes be a tough ask when it's not fully implemented with a system. It is a separate system that doctors have to go to, and that the pharmacist is having to pick up the slack with pharmacy approvals, and how can we improve the uptake of the system to make the doctors realise they are responsible for their use. So I know some sites are moving to mandatory approvals, and Royal Melbourne is moving to mandatory approvals on the 13th of September. And that's been a very large piece of work tied in with our implementation of a clinical sepsis pathway. And if any of you are interested in looking at the policies and procedures around that, I'm sure that Christina will be happy to share them. But it is important to move towards, and when you're moving to mandatory approvals, that really it's for the first time that you're going to be engaging with nurses at a very detailed level. And my opinion from going through this process is that they really are very keen to be involved in this process. They support the processes. They are the custodians of care on the ward, and so we can feed back to you how that will go after September. The second element, which all of us do, is post-prescription review, which is really probably the most effective element of stewardship, but also the most workforce intensive. And that means you need to be able to document what happens to the patient. You may or may have time to go back and look to see if your recommendations were taken up, but also that all of us have this desire to measure the impact of the service, because you do need to feed back to the executives and to the accreditors, how do you know your service is actually effective? So there's that element as well. But also the guidance reports in the past weren't particularly helpful in providing meaningful feedback, because simply just knowing your approval numbers or the common indications is probably not enough. You need to know, well, what were the indications and how and what type of interventions we do, were the recommendations taken up, and were there any serious events or the overall appropriateness of prescribing. And so these are the sort of areas that we're going into. The updated accreditation standards are becoming more detailed, and particular elements to highlight from that are that they're firming up on the restriction rules and approval processes, and it is clear that some hospitals are still using hybrid systems. Phone, traffic light clearly is a key area, and then the approval systems, whether it's guidance, easy ideas or approval processes. For example, Shepparton has developed one within their own hospital. So it is really interesting to see how that is going to continue to evolve. The other thing is that they're firming up on the antimicrobial stewardship clinical care standard. And for those of you who are familiar with that, there are, I think, 8 elements of that. And we haven't had a dedicated audit to do that. And some of it is more tricky because it actually relates to patient awareness and understanding, and how do we do that. And then the second element is what the stewardship program will do, which is now looking at antimicrobial prescribing and evaluating the performance of the program and the appropriateness. So it is becoming much more prescriptive than the previous one. So, like you, a lot of us have done work in implementing guidance and having reinforcing our policies and procedures and working at clinical guidelines. But there are now great opportunities now. So what are the opportunities with integration with electronic medication management? what are the opportunities with pharmacy integration? It allows you to capture a lot more patients, but the offside to that is the more you see, the more work it is. And ultimately, stewardship is really, well, I think a key area is triaging what you can do with the allocated EFT that you have. And so this is where we've spent some time with the post-decision review tool to, I think, recommend it as an essential part of guidance now. You might have seen this headline at Royal North Shore Hospital, and I'm sure that those of you who manage guidance will probably be thinking, yikes, our surgeons are probably the same. But it has meant that that there is much more media attention and expectations around compliance with antibiotic use, and this was a leaked report, but it certainly hit the headlines and had the health minister having to discuss what the issues were. So it'll be interesting to see what's happened in the hospital since then. I'm going to go into talking now about how we need to move into integrated solutions to try and take a more systems approach from front to end, and that includes the knowledge base and databases that we use to set up the approvals, how we undertake the approvals, what sort of integration we can do, and then how can that best support the post-decision review team and the stewardship program. So this is a graphic with a few new elements in it. So I think this grey big square is our universal indications list, and this is a huge piece of work undertaken by our team and led by Kath George to develop what we call a national indications list for antimicrobial use, and it really captures all the potential indications that might be used against antimicrobials and vice versa. It becomes the core data source that can support guidance indications, post-decision review, and ultimately the NAPS, so that if you have guidance or post-decision review, this will definitely support auditing for NAPS, because the indications list will be the same in guidance as they will be in NAPS. So ultimately what that means, if you have the UAL embedded in your Cerner system, for example, on the day of the NAPS audit, for example, you could run all the patients on a particular antibiotic. They will have had the appropriate indication against it, and see halfway there in doing your NAPS audit in terms of patient capture, drug dose and indication. We are now in various stages in various hospitals and how we've integrated our post-decision review tool and guidance. This guidance audit I'll talk about later. This is, I guess, the deep dive audits that we've been talking about that need to be done in hospital, such as RVORL audits. And so this is the centre grey box, which pulls together all the various elements of guidance, which are going to be eventually our piece of work we'll be undertaking next year, which will be the new guidance AMS. So the guidance as we know it will change. So instead of the DSML builder and the guideline builder, we'll be using the unique indications list as the core data set to map indications in antibiotics. It'll be much easier to manage. It'll enable you to triage, set alert indications, durations of approval, and it will be fully compliant with your post-decision review module. I'll discuss in detail the post-decision review. You might have heard it talked about in the past as iReview, but we've sort of prefer to talk about our PPR tool, the audit evaluation as well. So I'll step through the various pieces of work that we're doing at various hospitals and how that's going to influence your decision about guidance in your hospital. With EM integration, this has been a really great piece of work that we've been doing with Cerner in New South Wales, and currently now in Prince of Wales, when the user chooses a restricted antimicrobial, they're prompted to get a guidance approval, which opens up. They still step through the engine, take the approval and enter that back into the prescribing tool, which then supports their guidance auditing process. And this needs to then progress into allowing a seamless integration with the approval number being entered back into the electronic management process. And this piece of work will be completed in December this year. It also allows, once you're integrated with the electronic management system, you really have much greater pickup. It means that you can also monitor under the radar antimicrobials, so not just restricted antimicrobials, and it allows to set up a seamless process to trigger antibiotics that need attention with or without an approval. So a good example of that is, I'll step you through with what we're doing at the Epworth. It really does start to create a two-way integration. So ultimately what we're trying to do is a seamless workflow for the prescribers. So once you get them to actually do the approval, that means that they do not need a separate login. The application opens within, and the patient and the drug selection seamlessly go into the guidance approvals that need attention, and then we'll step into the post-prescription review. What has happened in Prince of Wales and SASI network is it's massively increased the uptake for restricted antimicrobials. Made a huge difference, and actually the users really like it, because at the moment in many of these systems there are no ways to really introduce clinical guidelines at the point of prescribing. So for example, neither Cerner in particular, there is no way to currently open up a guideline within Cerner. So allowing that integration with guidance means that you can actually see the clinical recommendations, either local recommendations or the therapeutic guidelines recommendations. The model that we're doing at Epworth, which we think is really exciting, is that it's a different model of care, of course, because it's a private hospital. There aren't junior doctors. Doctors are not the ones who are going to be doing approvals, and yet they needed to be able to capture what was happening. Epworth has an associated pharmacy, so that all antimicrobials, they are not on impressed, all are dispensed. And the system that they use is Fred. And so what is happening there is that the pharmacy's dispensing system is broadcasting all antimicrobials into guidance, which generates an automatic pharmacy alert that is automatically available immediately into the post-prescription review tool, which can then target the rounds and the interaction for the pharmacists on the ward. And a classic example where you can modify what you want to review was the use of IV metronidazole, because metronidazole has not tended to be a restricted antimicrobial, of course, but IV metronidazole is expensive, and so they were noticing a lot of IV metronidazole. As you know, it's one of the key drugs that we can say, well, you don't need IV metronidazole. So they now switch on and switch off under the radar or target antibiotic to target within their review. It's a really interesting model, and it's been very well taken up by Glenn and the team there. So PPR, all of us do it in a particular way, but it is very labour intensive to actually measure and report what we do. The Americans have finally cottoned on to post-decision review. As you know, they've always taken a front-end approach to stewardship with their very high uptake of electronic medical records and CPOE, and traditionally many of their publications have been around front-end rules, front-end alerts and triggers, and order sets. And our argument back to Sarah and other stewardship physicians in the States has been, well, that's all very well. You might improve the compliance with guidelines through that methodology, but the real issue is about what happens after the drug is prescribed, you still need to review that patient, you still need to make sure there's de-escalation, and given 60% of our work is de-escalation or stopping, that still needs to be done by people. And so the Americans are finally cottoned on to the fact that that perhaps post-prescription review is becoming more important. So our PPR, which we've been in place, I think, for a good while at the Melbourne now, is and is being adopted now, sorts out the list preparation from guidance. So previously, where you have gone through antibiotics and need dispensing, allows a much easier list preparation. You can identify which patients are already being seen by the ID. It allows multiple antimicrobials to be used per patient, and it designs the AMS rounds by ward or unit, and is very flexible how you set that up for patient review. It then allows you to capture the interventions and then select post-round assessment if you need to, either after every round or on a selected group of patients, and then finally provides very nice dashboard reports that you can send to your units or wards or executive for the AMS committee. So it sort of obviates the kind of reports that we've had to struggle with in the past in terms of trying to explain what numbers of approvals or programs of prescribing. This is something which is much more effective. And the other good thing about the PPR tool is once it's in place, it's backwards and forwards compatible with guidance. So while you're seeing the patient, you can either extend, discontinue, or change the indication. And finally, if you want to, you can also include other patients for review. So you can manually add patients on the trot that may not even have a restricted antimicrobial, so it's not dependent on having an approval in guidance. And you can also set it up for particular triggers. So, for example, you may want to be able to view patients that have had a gentamicin level done, patients that have a vancomycin level done, voriconazole level, POSA levels, positive staph bacteremia, C. diff. So you can actually add in patients for your stewardship service. So it really provides a more broader post-prescription review opportunities, really. And of course, it is tablet compatible, which is a key requirement for our pharmacists. And there's been lots of evidence about the issues in hospitals with Wi-Fi, and that indeed was one of the things that we found in the Royal Melbourne, because of Wi-Fi, there are Wi-Fi black spots. So we've made sure that the system supports Wi-Fi dropouts and that you don't lose data while you're doing the round. We know that having the PPR reduces your list preparation time by 90%. As part of the PPR, you can also schedule reviews. So you can also collect things like the patient is not there, because it's really about kind of understanding the amount of time required to do stewardship, and it allows that kind of workforce documentation about what the service actually does. So it does take time to go to a ward, and then you go there and then the patient file's not there. That's real time and cost. The reporting and the communication, one of the opportunities that we have, and it really depends on what other electronic medical record you have in your hospital, is that the recommendations can be exported out and inputted into the hospital's EMR system. So it could be time-stamped and identified as an AMS review note. And how we do that is configurable to the system that the hospital has. And that would be submitted as a type of a template. I've already talked about that, but it specifically allows you to monitor how many of your interventions have been accepted, also to document the significance of interventions, because, as you know, there's RiskMan and other risk monitoring systems in hospitals where the pharmacists are actually entering. Cheryl, what's it called that you do it? What's the thing? VIMS. VIMS, yeah. Does every hospital do VIMS?
I'm
not sure. Anyway, there are others like Peter Mac, we have VIMS. So sometimes there are different ways of, we know that there are different data sources for drug incidents. So we thought it's quite important for the AMS team also to document if there are serious incidents, because they are worthy of either progression to a risk man or submission to an adverse events or patient safety committee, and all of us will have stories where we've really averted a serious adverse event because something that we've found in our AMS rounds for sure. We are going to be using it to support a telehealth model stewardship, and the site that we're kicking off with is Shepparton. So Shepparton has their own approval system that was developed in-house, a relatively simple one, and we're integrating that with the PPR, so it doesn't depend on guidance at all. And we're going to be using that off-site together with the pharmacist on-site to undertake the round, and it allows that the advice to be clearly documented and to also collate information for the Shepparton base. So that's a project being run through with Tom Schultz, which is really exciting. And there's many rural regional sites that are looking for that remote support, and we are very keen to look at this model. So just a little bit more on the unique indications list. It's been something that we've been wanting to do for a long time, and it was a huge amount of work. We have, perhaps I'll go to the next slide, which explains a little bit better, but it was very important for us that the list itself would be something that would be formally coded up using the SNOMED code, which is an international data set for clinical terminology, and it's routinely used in large decision support systems in the healthcare setting. Many of the pathology systems do actually have embedded SNOMED codes for diagnostic codes, for example, for histology. We also recognise that we need to move beyond the guideline builder and to save the amount of work for future-proofing guidance to manage content, so that we can move towards a cloud-hosted service with local lists, and when there are new indications, that it's managed through a centralised committee. And ultimately, it's to create that interoperability between all the e-health systems out there. We have used various sources to get our final list, and the obvious sources have been indications that have long been used in guidance, which there are about 400, therapeutic guidelines, and then we had specialised groups from various areas like paediatrics. It allows the tagging, for example, for an EMR site or the CPOE site like Cerner, when there's a 40-character limit, it means that they can still use the indications with their own alias, which fits their indications list. And it also allows tags so that you can search, easily find clinical indications. So we went through a process in 2015, as I said, with indications from guidance, therapeutic guidelines and NAPS. We did a lot of testing across the indications to ensure that we finally came up with what we thought was a good list. We clearly defined what was an indication, what was a definition. We had a unified and consistent approach. We wanted to future-proof the use of the list so that there are many indications, for example, that weren't well captured in either TG, NAPS or guidance. A classic example would be the medical prophylaxis indications, where we really thought clearly about trying to improve the granularity of that, because as you know, I think it's the third most common indication in NAPS, and yet it doesn't give us enough indication what it actually is. And we also include infections that don't actually need an antimicrobial, and also indications where antimicrobials are used, like graft versus host disease, which is actually not a condition, but it is an indication for antimicrobial use. Then there was a lot of work with usability, and finally implementation. So this month we are implementing it within our post-decision review tool and with the targeted NAPS audits at Royal Melbourne and also PEDAMAC, and then it'll be formally launched as part of NAPS next year. It will be back-coded with existing NAPS indications, so it means that the NAPS reports will be able to be comparable from one year to the next. So that's really important as well. In terms of managing the content, we thought that this was very important, and it's kind of some of the, I guess, the philosophy of NCAS now, that we try and establish NCAS as a source of truth in terms of our in terms of the data sets that are going to be used for NAPS and to maintain that code set. And this process was also undertaken with NETA, which was a National eHealth Transition Authority. And it's part of our process now, where we will be reviewing all requests for changes, and I'm sure once it starts to become embedded, we'll start to hear from our users. But keep in mind that we've done NAPS for 4 years now, and while after the first couple of years there were lots of requests, the requests have been relatively stable, but we know from ourselves with the NAPS data, we've got well over 100,000 indications now, but there are things we need a little bit more information about. And if we are going to start doing deep dive audits, we need to be able to have a more inclusive set of indications. This is a screenshot of what it looks like, and you can see it's set up in terms of system types, indications. You can add tags, you can create aliases, and the way it would work is that the local site would have their own list that they would manage, but it would be centrally mapped back into the centralised management portal. Guidance and NAPS is really something that I'm very passionate about, because I don't think we need to be smarter about how we audit, and that if we are doing audits, that we can use that not only for your own institution, but to support national benchmarking. And this is where all the data can be centralised. I don't think we can do the deep dive audits with it while we can have detailed audits in NAPS, because deep dive audits require patient-sensitive information and results. It's likely that the module will need to be sitting, the database will be needing to be sitting inside a hospital, as opposed to the de-identified benchmarking that we do with NAPS at the moment. And so we're going to be calling it guidance audit, and this will pull in data from all data sources, including EMR, pharmacy dispensing guidance, and the post-decision review PPR tool. It'll be a very powerful way to actually start to do very granular and what we call deep dive audits to look at specific practices or practice change. You know that there's a hospital NAPS, the aged care NAPS, the QI NAPS, surgical NAPS, but we are keen to, at the moment we're doing a hospital and home NAPS project, which is being led by Deb Freedman down at Geelong. We're about to do the GP NAPS, and we're working with the vets to look at veterinary surveys as well. But these are things that all of our users have come to us, and I think it's an obvious issue how we can get out more data for practice change. So, for example, antimicrobial audits, vancomycin audits, Mero, antifungal audits, for example, and then indication-based audits like CAP and UTI, cellulitis. These are indications which are not defined just to hospitals, actually. And if we look at aged care, for example, in general practice, respiratory tract infections, urinary and skin infections are the top 3. So we're really trying to develop audit tools that will be applicable across the healthcare sector. We've also had requests to have standardised SAB audits or CPE audits, CDIF audits, NAVIA or SWITCH. Victoria is a little bit unique because we have VICNIS, and VICNIS actually has CPE and CDIF mandatory reporting, but some of these qualitative audits are not routinely available all over Australia. So I think it is something that NCAS and Guidance are uniquely placed to develop these standardised approaches. And as I mentioned before, these audits where we are using data that's already available from Guidance and other systems makes it an obvious next step to develop up the audit module. NAPS this year. New Zealand's already been doing NAPS, but we're starting to work with all sorts of people across the world. Andrew Morris in Canada and Marion Kaner in Tennessee and Oxford in the UK. It's a very exciting process. So I've always said to people we have a lot of data and we are very collaborative, and I've always invited our pharmacists who are listening in to consider doing a project with us in looking at data, publishing something, and the offer still stands. Very, very happy if you wanted to look at a particular drug indication or whatever to undertake a research project for SHPA or ASA or something like that. This is what our data set is for. And similarly, we're very keen as Guidance gets upgraded to the AMS program, pulling all the modules together, that we are able to look at the data from multiple Guidance sites. It will be a very powerful way of looking at the impact of AMS. So just finishing up overall, we recognise the amount of work that you've been doing with Guidance in your institutions. We know that it needs to fit better with the amount of auditing and reporting that we're being asked to do. We think the PPR is a core element now, and from my point of view, it'd be hard to imagine not having the PPR tool as part of our ward round now, just because I can see in front of me where the patients are, what they need, who has already been seen by ID, and reviewing recommendations that you've made in the last time you saw them electronically instead of having to search through the notes, and then most importantly the dashboard reports. And I think the important point, we had an ICU that traditionally refused the approvals because they saw no benefit of doing the approvals. They kind of half-heartedly would do an approval as a patient left the unit. But once we were able to show them what the dashboard report was in terms of appropriateness of use and what they were using it for, it was a complete 180 degree turnaround, and our ICU now is one of the highest approvers in the hospital, and it's been a very powerful way to drive awareness of their usage in the unit using the post-decision review data. And finally, from my point of view, it's really important that we do create consistent definitions and that we can actually create data that is comparable across hospitals and sites, and to create that interoperability. So I'll leave it there. So I'm going to unmute you all. Hang on. Kath, did you want to say anything to the team? You're online and you've been doing a lot of work with the unique indication system, the specifications for the Guidance upgrade. Did you want to make a comment?
Kath is actually coming to your office. Her microphone is not working, so she'll be there in a few seconds.
Oh, okay, that's right. Are there any questions from anybody else? I'm just making sure that you're actually unmuted here. Maybe please feel free to type a question if that's easier.